The game of life is the game of boomerangs. Our thoughts, our words, our deeds all come back to us sooner or later. But all that we go through in this journey, our experiences, our gifts, and above all, wake up calls. Welcome, ladies and gentlemen, to Dr. Tapaswini's Corner. That's me, and I work as a head and neck oncosurgeon at Fortis Hospital, Delhi. To sail through the dark clouds of cancer, one needs to have a correct attitude, approach, and knowledge that makes a great difference when you're riding through the tough times. Many of us know about leukemia and lymphoma, but few know about multiple myeloma. To throw light on this disease, we have our expert today, Dr. Dinesh Bhurani. You are the director of the Department of Hemato-Oncology and Bone Marrow Transplant at the Rajiv Gandhi Cancer Institute and Research Center, Delhi. Having trained yourself from CMC Vellore and from Australia for bone marrow transplants, you are a leading hemato-oncologist of India with 20 plus years of experience and more than 1,000 transplants to your credit. Besides your pioneering work in this specialty, you are reckoned as the first doctor from North India to have performed a haplotransplant with success. Welcome, Dr. Bhurani, to the show, and it's indeed an honor and pleasure to have you today.
Thank you, Dr. Tapaswini, for inviting me. It's a really pleasure to be on your corner.
Thank you once again for being with us. You know, years ago, multiple myeloma was a hot topic of discussion in the media circle. And that's because we had our famous actress, Lisa Ray, who was diagnosed with the cancer and had a bone marrow transplant. So, Dr. Bhurani, tell us, what is multiple myeloma?
Before we go through, I'll just tell you, it's not only the Lisa Ray. Our two Prime Minister, Mr. Chandrasekhar and BP Singh, both had a multiple myeloma. They may not be highlighted
Right, correct.
in media, but they both also had a multiple myeloma, and they lived longer with the disease. When you say what is multiple myeloma, is one of the cancers, is a cancer of one of the white cells which are produced in the bone marrow. Is called a plasma cells. When the plasma cells are produced as a cancer in high numbers, they don't do a normal functions of protecting the body. They produce an abnormal protein which is harmful to the body.
Okay.
So that's a cancer of bone marrow, which is a plasma cell tumor, and that leads to the destruction of bones because it is multiplying in the bones. It leads to the renal failure in some patients, and it reduces the immunity of the body because the normal cells will be reduced because of the cancer.
Okay. So what a lay person would understand, because there's a lot of destruction happening in the bone, so there would be invariably some weakness which would be produced. So how common is this cancer in our country?
The incidence of this cancer is not different in our country in comparison to the Western world. So it is usually a 1% of all the blood cancers. So of the blood cancer. So it is rare, but it's not very, very, very uncommon. So as the age grows, many of the older age group people can have a multiple myeloma.
So is there any particular age group that it commonly affects, or is there a particular age group which has a predilection for this cancer?
Usually, this is a cancer of old age. The more you grow older, the frequency of having a myeloma increases. In comparison to the Western world, many of the younger patients also say the incidence is 1 decade earlier in our country. So probably we see many of young age myelomas too. But more you grow, the incidence of myeloma increases. Is not seen in children. So it's not a disease of children, rarely in the young age group, more common in the elderly.
Right. So I think it will be very useful to know as to what are the various causative factors in this particular disease.
Usually there are no causative factors. you cannot contribute some lifestyle or some the personal habits to contribute to. It is related to the age factor. So normally the body produces the response as antibodies to the infection. So if you have a multiple infections or some chronic inflammatory reactions, that can lead to this tumor. But there is no direct factor. Usually there is no genetic factor to contribute to the myeloma. So in short, we don't know the cause. We cannot say preventing by personal habits or any environmental things which can prevent it.
So smoking and alcohol, which has been generally most of the time the causative factors for other cancers. So it doesn't play any role in this particular disease?
There's no direct relationship with the smoking and alcohol. Like you have a lung cancer, esophageal cancer, which has a direct causative factor with the smoking and the lifestyle habits. There's no direct factor, but probably there may be some indirect relationship with this. There's no proven causative factor with the smoking and alcohol.
All right. But then how does one suspect this particular disease? In other words, what are the signs and symptoms of multiple myeloma?
Unfortunately, the symptoms are usually vague. So it affects the multiple parts of the body. You cannot say A symptom or B symptom, you have it and you have this myeloma. So as I said, it affects most commonly the bones. The bony pains are commonly the people have it. So you can have it with a vitamin D deficiency or with some muscular pains. You can have the pain. So there are more common causes of bone pains than the myeloma. And that's how it is ignored. Sometimes it affects the kidney. So there are multiple causes of having a kidney failures. The myeloma is one of the causes. So many times the diagnosis is delayed because there's no specific feature. I can tell you that this is a feature. Some people can have a low hemoglobin, and when you investigate them, and there are 1,000 causes of more common causes of low hemoglobin. So the myeloma is a rare cause of low hemoglobin. Myeloma probably is a rare cause of renal failure. Myeloma may be the few of the less common causes of bony pains. So these are the features which can be there. There are more common causes for these presentation, and it's not that everything will be present in everyone. So someone will have a presentation with the low hemoglobin, someone will have with the renal failure, someone will present with the bony pains. More commonly, the people present with the bony pains, and then once you see the doctor's responsibility lies whether we are dealing with the less common causes of bony pains.
Can it be also asymptomatic and it's just picked up incidentally on investigations for some other disease? Does it happen that way?
Now, more commonly, the people are getting investigated. The routine investigations are done. So sometimes on the investigations, you can see a low hemoglobin and then they get investigated. Sometimes the calcium is high, then you can get investigated. Sometimes your protein levels, which are the abnormal proteins levels are high, and then you picked up. So you may not have a symptoms. And you can be picked up. One thing I should say, before the myeloma, you have a pre-myeloma syndromes. One is called MGUS. Another one is called a smoldering multiple myeloma. There you have abnormal proteins which is produced by these abnormal plasma cells. So these are pre-myeloma phases of cancer. Don't have any myeloma related symptoms. You can be labeled as a MGUS or MGUS or smoldering myeloma by the test, not by the symptoms.
So how do we investigate? What are the various investigations that we ask for? And tell us, what is that investigation which would clinch the diagnosis of multiple myeloma?
When to suspect it, when I said it can present as a low hemoglobin, it can present with the renal failure, it can present with the bony pains. So someone with being investigated for low hemoglobin can found to have some test done and found to have a low renal failure. You can find do a test and then you can suspect it. So suspicion will be with the hemoglobin, renal failure, and bony pain. Sometimes you can have X-ray which shows you the typical lesions, and then you investigate that and found to have the multiple myeloma. The one of the test is called to find out whether you are producing abnormal protein is called a serum protein electrophoresis, or more sensitive test is a serum immunofixation. So the protein is present in your blood, and you can find out. This is one of the blood tests. but is not routinely done. Whenever you suspect it and do this test, the majority of the myeloma produces this abnormal protein, and you can pick it up on these tests. Some of the myeloma do not produce this abnormal protein, and even if you do these tests, you may not find them. The most definitive test will be a bone marrow test, which is done later part of the test. So initially is a blood test, or you do X-rays and find out some abnormal these things are there, and then you do the further test. Among them, the bone marrow and PET scan are the most sensitive test, the more confirmatory test, which can confirm the diagnosis.
Right. So there's something called a gene expression profiling test that we do for this particular disease. Is this something which is routinely advocated, or it is done only in specific situations?
For diagnosis, we do not need a gene profiling. So once you do a diagnosis, is on the blood test, on the X-rays or PET scan, on bone marrow. So these are the tests we do it. Sometimes you do a urine test also. The abnormal protein goes into the urine, and you can pick it up on the urine test also. So for diagnosis, no gene profiling. For prognosis, how good or the bad is your myeloma, we do a certain test. Among them is most common is the FISH test, where you see a genetic abnormality. So certain myelomas are bad, which are considered as a high-risk myeloma. They have some genetic changes, which we pick it up on the FISH test. Is the common test is called a FISH test. Gene profiling is more sensitive test, but it's very cumbersome. It is available in a very high academic institutes. Even in India, not every institute has it. So you don't need them. So there are a more common tests which can tell you you have a good myeloma or bad myeloma. So actually, very rarely you do the gene profiling.
So this bad and the good variety, the risk stratification that we do, what is the main crux of this stratification? What all points do you put in to classify a patient to be in a good category and the one in the bad group?
One of the tests is called, one of the prognostic is called is the ISS, International Scoring System. And then they have revised it. It's called a revised ISS, it's International Scoring. So that determines your good or bad. Among them, as I said, the genetic changes plays an important role, which we pick it up by the FISH. So there are certain changes which you pick it up on the FISH. They are bad, certain are reasonably good. So the FISH test, then your albumin level, so the protein level, the normal protein levels, how significantly have gone down. And there is one of the tests is called LDH and beta-2 microgram. So there are certain blood tests and there are certain genetic tests which determines how good or the bad this myeloma is.
Great. So now let's talk something about the treatment. Do all patients of multiple myeloma warrant a treatment, or there's some category which may not be required, where you do not require?
I think this is a very good question. Not when we label it as myeloma, then you need a treatment. As I said, there are pre-myeloma stages. One is called MGUS, another one is called a smoldering myeloma, where you do not need a treatment. So you have a precondition. Many patients may be asymptomatic, remaining stable for many years, and do not require a treatment. So you may panic, you have this, but treating early or treating when you change to myeloma, when you progress, does not make a big difference. So sometimes you have this abnormal protein, sometimes you can have a certain plasma cells in the bone marrow. So certain changes you can see on the investigations, and you're not labeled as a myeloma, you are still labeled as the different categories. You are diagnosed, but you don't need a treatment. But once you are labeled as a multiple myeloma, that implies that your body is getting destroyed by this cancer, or you're likely to be destroyed in 1 or 2 years. That's a time when you need to be treated. So myeloma needs to be treated, but the preconditions do not need to be treated.
Okay. So what all are the treatment options that we offer to our patients?
Once you are diagnosed as a myeloma, we treat it loosely, you call it as a chemotherapy, but the regular chemotherapies have been replaced by the targeted therapies. So the majority of the patients are treated with the 3 drugs. One of them is called botensilimab. This is one of the targeted therapy. The another is called a lenalidomide. That also is a targeted therapy. And a steroid is called a dexamethasone. So the combination of these three drugs in a various doses depends on the age and your the tolerability are treated with these three drugs. So initially we have to control the disease with these three drugs. Then if you are eligible for the transplant, which is usually determined by your age and your performance status, whether you can tolerate autologous transplant. I'll come to this, what is transplant and autologous and allogenic, but is autologous transplant. And then it's called a maintenance. You again introduce the same drugs in the low doses to maintain the whatever you have achieved with the chemotherapy and the transplant. So you call is an induction, controlling the disease, then whether you need a transplant or not, then maintenance to maintain the low level of drugs.
So now that we are talking about bone marrow transplants, tell us who are the ideal candidates and when does this indication come in the treatment?
The idea is to control the disease with the induction targeted chemotherapy. Once the disease is under control, 50%, 70%, 90% control, then you consolidate with the autologous transplant. One unfortunate thing with the myeloma is it is incurable. So the disease keeps coming back after a few years. So what we are trying to do is to prolong the first remission. So prolong that the first time coming back should be delayed as much as possible. So you control it and then consolidate with the autologous transplant. You asked me who needs it, who should go for the transplant. All the patients who can tolerate the transplant should go for the transplant. So who can tolerate it? In India, I would say the people who are less than 65 and fit enough. Fit enough is their lung, kidney, and heart are good enough to tolerate the transplant, should undergo for the transplant to prevent the first relapse. So we can prolong the life by delaying the relapses.
Okay. So when we say autologous bone marrow transplant, how does the listener interpret this? What does it actually mean?
Actually, the transplant is misnomer. Previously, we used to do it from the bone marrow, so that's why you call it as a transplant. When you take the stem cell from one person to the another person, then you can say you have taken from a person and transplanted to the another person, then you can call it. Autologous means when you use your stem cells. So stem cells are the mother cells, which are in the bone marrow, which produces the normal cells. So what we do, we stimulate the bone marrow. So these mother cells comes to the blood and we collect them from the blood. So you go on the machine, like platelets are collected, you collect the stem cells and then you put it into the fridge. And after that, you give a very high chemotherapy. If I give that high chemotherapy without keeping the stem cells separately, your body cannot tolerate that this thing. So what I have done, some like a seed, I have collected some seeds, kept outside, given a heavy chemotherapy, preventing them to be exposed to this chemotherapy, and then put back that seed and replanting it, means regrowing of these seeds to make the normal cells. So basic idea of this autologous transplant is the chemotherapy, which I cannot give you the normal person, take the seed out, give this heavy chemotherapy and put that seed back again to replanting it. So that's an autologous transplant. The aim is to give a heavy chemotherapy to kill the more cancer cells.
Okay. So does this have any implication on increasing or improving the survival scores of the patient?
Definitely. The myeloma treatment has taken a huge progress. There are multiple. If you asked me when I started my training, we had a melphalan and prednisolone. There was only two drugs which for the many years, whoever comes in get treated with these two drugs. Now we have a multiple targeted therapies. In fact, one of the targeted therapies called CAR T cell therapy. You train your T cells to kill the cancer cells. So you just modify them and give them back. So there are multiple options available. Now we are not using a chemotherapy. We are using a targeted therapies to control. But whatever has come in has not replaced autologous transplant. So the survival has improved with the target. It says the survival was this much, with the targeted it has gone up, but still the transplant is relevant because that improves the survival because it is incurable disease. This is one of the most effective therapies. Is still there may be an era when after 5 years or 10 years we may have a more effective therapies and that can replace a transplant. But there are a lot of trials have been done to show that if you add a transplant along with these targeted therapies, the survival improves.
But when we look into the literature, the survival figures of multiple myeloma cases is so variable. The range can be from 1 year to 10, 15 years. What are the various factors? Who are the patients who would be good survivors, we say?
When I said we divided into two groups, the good
Right,
myeloma and the bad myeloma. So high risk
right.
myeloma and the standard risk. So there are two groups. One is a high risk. As I said, the risk lies into your genetic changes, which happens when the myeloma develops. So that's and the how much stage. So if someone has delayed the treatment for longer, the myeloma is more spread, then you have a higher stage. So someone who has a higher stage has a bad myeloma. The survival can be as low as 2 years also. Whatever we do, we still lose them in 2 to 3 years. So the survival can vary from 2 to 3 years. Majority, as I said, the 20% of the myelomas are in the bad group, 80% of the myelomas are in the good group. Usually they survive more than 5 years, and some of them the survive for the 10 years also. The survival is prolonging to the 7 to 10 years because of the new drugs and the new treatments.
So it's important to know how we can prevent this disease. Is there any way that one can prevent, or it's something which is not in our hands?
If you ask me, the straight answer is
Yeah.
not in our hands.
Okay.
But having a healthy lifestyle, having a probably there is some indirect relationship with the tobacco, smoking, and alcohol. So having a healthy lifestyle probably can prevent it, but there is no direct causative factor. So
Okay. Right.
we cannot prevent it.
Okay.
We can diagnose them early. So if you have a suspicion or if you have some symptoms, you go to the doctor. Doctor should suspect. Among the causes, you should still suspect that this can also be there, and we diagnose early. We can treat them and give them a longer life. So diagnosing in early stages can help us, but probably difficult to prevent it.
So even a simple backache, which may be prolonged for a long time, should not be ignored. One should go and see a physician and a clinician.
Yeah. So the backache is not always is just a vitamin D deficiency or some muscle spasm. It can be something serious like myeloma too.
Right, right. So what I figure out from our talk is that relapses is also a story with multiple myeloma, frequent relapses. So what do we do for their surveillance? How do we follow these patients up when they come to us?
I would say stick to a doctor. So if you like your doctor, stick to that doctor. If you don't like a doctor, change it to the B, but you follow the instructions of the doctor. Okay. We do a test. So every 3 months or 4 months or 2 months or monthly, we do a test to find out whether your myeloma is coming back or not. Fortunately, we have a blood test available. As I said, the abnormal protein can be quantified so you don't have to do the bone marrows and PET scans again and again. By the simple blood test, we come to know before you develop a bad symptoms, we come to know by the test whether your disease is coming back or not. Even the test shows us some coming back. It's not necessarily everybody needs to be retreated again. Sometimes you can wait for this to grow enough and then you start a treatment. But you need to be on the regular surveillance, your doctor doing the test and finding it out whether your disease is coming back or not.
So how challenging do you find when the diseases relapse and when they become refractory? How challenging is it for the clinician?
More challenging is for the patient. They get disappointed. Whatever you tell them in the front that your disease can come back, once you have gone through the initial treatment, gone through the expensive transplant and complicated process, then and you have a good quality of life for a few years, you tend to forget that the disease can come back. So they usually you face the patient who is in a denial mode that the disease has come back. Sometimes you have a patients who can be very sensitive. They panic it on that why the disease has come back, and now the disease has come back, my life is gone. that kind of things.
Right.
But we know the disease is come back. It can be controlled. So we have a multiple drugs or many targeted therapies which can be used in the subsequent relapses. Sometimes we do a transplants also to prolong the survival. So the disease come back it doesn't mean that something is going to happen soon. You still have many more years with the newer drugs.
That's a great respite, for the patients.
Yeah.
Even with relapses and the disease being refracted, there's always something to offer to them.
Yeah.
Thank you so much, Dr. Bhurani. I hope do you have something else to add to the end of the program?
What I'm trying to say is a chronic disease.
Okay.
So it's not like this comes and goes and comes and goes for the majority of the patients. As I said, the bad disease usually is a bad disease which we cannot do much so far. There are a lot of research is going on. There are a lot of newer drugs and newer therapies are coming in. So what we are trying to do is, though it is an incurable disease, we are prolonging the life with giving a good quality of life with the multiple treatments.
Right. Lovely to hear that. There's so much of hope for everyone. After we've had this discussion, I'm sure a lot of people would have benefited out of it. Thank you so much, Dr. Bhurani, for enlightening us.
Thank you, Dr. Tapaswini, for
on issues on multiple myeloma. Thank you once again. Life is too ironic. To experience happiness, one has to grow through sadness. So there are many chapters in our life, but it's wise not to lose in the one we are now. So be thankful to everything that happens because it's all an experience. Thank you so much. Thank you so much, Dr. Bhurani. Thank you to all the listeners. See you next week with another episode. Till then, goodbye.